Welcome back. We have one more very special session for the rest of this morning. We'll explore how cities, where nearly 70% of the world's population will live by 2050, I believe the current percentage is around 55%, can become lighthouses for health and resilience. With the right partnerships, urban spaces can go beyond managing diseases to truly building smarter, healthier, and more inclusive communities. This session is in partnership with Concordia's principal programming partner, Novartis Foundation. Please welcome to the stage Nicole Roberts, founder of Health and Human Rights Strategies and host of the Global Good podcast, and our panelists.
Hello, everyone. This is excellent. I'm so happy to be doing this. And as you see, we'll have some other guests join us soon. But to start, I am joined by Aerts, head of the Novartis Foundation, and Juha Jolkkonen, executive director of the city of Helsinki. So ancient cities to modern day urban networks have shaped the course of history, and they will continue to do so into the future. And yet, there's a bit of a paradox when it comes to cities. While they're a place of opportunity and innovation, there's also inequality and social discrepancies. And so as we gather, I want us to ask together as a group, how do we reimagine cities? And how do we harness the power of cities to not only drive economic and political progress, but also to advance and protect the health of urban populations? So I'm going to start with a question for both of you. And I'd like to know, you guys have all this firsthand experience in cities around the world, to be at the forefront of innovation. But what do you think are the main success factors for a blueprint to build health and wellness?
Well, I think, as you said, cities are getting more and more important because of urbanization and people are moving to cities. Cities are closer to people, cities are closer to the families and communities. Cities are responsible for many of the services that are close to people. So cities can really influence on health and well-being. And cities also, I can see, or I would like to see cities as communities, not just the city services or the organizations, but also, of course, third sector organizations, private sector, and citizens and families, of course. So cities can be the platform of this kind of actions.
Excellent. Anne?
Yeah, I think cities can definitely be drivers of population health and well-being, but they have to do that. The first condition for me is that they use data to understand what truly drives their health. So if they use data to make the decisions what kind of sector should act on what kind of issue, then they will be more successful. So a second condition is the intersectoral work, like you do in Helsinki. You work with the social sector, but also with the transport, the sports, the housing, you name it. All these underlying drivers of health have to be included in the roadmap towards better well-being in a city, I believe. And lastly, the city has to listen to what the citizens are thinking, so they have to understand well what lives in their populations, that they can make the whole approach to better well-being people-centered.
Excellent. And for you, Anne, how and when did you realize the power of data in terms of driving healthier populations?
I think since a long time, but definitely let's take the example of cardiovascular disease. We know we have all the scientific progress over the last decennia. We made the best scientific progress was in cardiovascular medical care. And see, we improved the life expectancies quite dramatically thanks to that. And still, cardiovascular disease is the first cause of death and disability in the world. So we seem to miss a piece of the puzzle there. We seem to do something wrong. And that is why we don't really understand what drives cardiovascular disease. That's where my passion comes from, that we have to use the data to understand exactly in what kind of place and what kind of subpopulations the drivers of cardiovascular disease can be identified so that you can act upon it properly. Mm-hmm. And that is where it started. And that's what we do also with our program, AI for Healthy Cities.
Yes, and we'll talk more about that once we have our other panelists join us. Juha, in your city, you are combining data from different health and health influencing sectors. So, to identify leading social, economic, environmental determinants of health. And, how are those data-driven insights being translated into solutions, as you just described?
Of course, we need to go and see the results and analyze it with our experts. But I think we can find already some social determinants, as you said, not just social and health, so-called traditional risk factors, but social determinants of health. For instance, we have found from the preliminary results that we, for instance, have groups like women with stable but rather low income, families with children or no children or smaller families, and for instance, people that have families that have a high debt burden and so on. So as Anne mentioned, we can target our interventions. We can also allocate resources to find these people and these situations. And on the other hand, for instance, we have found that actually very young or middle-aged men with a high education or high level of income, they do have sudden strokes. And that's another kind of a group or aspect we need to consider. How do we approach them and how do we make their health and well-being better? And of course, you always have to remember the population level. For instance, physical activity has been, from our results, a very important aspect when you try to promote health and well-being. For instance, with people or with groups that had no metabolic risk factors, whatever, physical activity increased their lifespan for about 8 years.
Yeah.
So physical activity is very important even without any other risk factors. So these are just some highlights from the 250 slides we already have from the results. So just a few of them. Mm-hmm. And of course, we're going to do a welfare plan. We've already had a welfare plan before, but now we're going to do a welfare plan within a city, not within the social and healthcare sector, but within a city with all the city actors. And we're going to set goals, targets. We're going to set a follow-up that everyone is involved in building up health and well-being basis for all the citizens.
Wow. So Anne, building on that, how can cities use data to identify and address differences, in life expectancy, health outcomes across geographies and populations? And how do we move from reactive to, being proactive, preventative even, to keep people healthy?
Yeah, that's the main question, of course. But every city is facing these differences in life expectancies. You can see here in New York, a baby that is born today in one zip code has a 12 years life expectancy difference with a baby born today in another zip code. In London, you have a 2 years decrease in life expectancy every stop of the subway. So you see that in all of the cities, and we need to understand what drives these differences before we can address them. And that's how data, when you combine the data from all the health sector, the hospitals, the primary care centers and others, with data from all these influencing sectors, be it transport, food, sports, housing, security, you name it, all the social, environmental and economic determinants, then you can quantify which determinants are mostly driving your cardiovascular outcomes. And that's what we set out to do with AI for Healthy Cities. We've seen that diabetes in New York, when we use all of the US data, you can perfectly predict diabetes per census tract in New York City based on 3-4 factors. And the first one is low education, low income and low education is always the same. Lack of internet access, living alone, social isolation is a very strong factor. And all of these things can be addressed, but not necessarily by the health system. If you look at hypertension, it's all about the commute time of people. That's the #1 driver of high blood pressure in New York City. So that's not going to be addressed by the health system. We need to work across sectors. And that's when you make cities and their health systems become proactive. They move away from this passive reactive care systems where they wait for people to get sick to become proactive. And if they use the data then to build predictive tools, they can ultimately become preventive and true health systems that they keep the populations healthy.
So Juha, in your experience, based on everything we just said, how do we ensure that health is prioritized alongside and or within these various components, the infrastructure, transportation, housing? What recommendations do you have?
Well, I always like to start by saying that social and healthcare is responsible for about 20% of health and well-being, and the rest of the 80%, is based on something that someone else has to do. And we know from the analysis that, for instance, cardiovascular risk factors, you can find so-called non-traditional risk factors like traffic noise or tight living spaces, urban environment, higher volume of traffic, and so on. And that's why you need to have a holistic approach within the city and with all the actors responsible for urban development, for housing, schools, sports and leisure, and so on. And that's why I need to involve everyone. And that's, as I said, we're going to do, or we're using a strategic welfare plan that everybody is involved, every part of the city organization is involved, and we're going to set targets and follow them up. Health and well-being is not a separate issue. So you always have to remember, we used to have years that health and well-being was always social and healthcare issue, but it's not so. And that's what we have been doing, this basic work with our people, with our divisions for many years now. And we're using a so-called health impact assessment in every decision-making, for instance, when they do decision-making in urban planning or in schools or in sports, they also need to do an assessment. How does this affect people's health and well-being? And that's how we can also bind the decision-making in everything we do within the city. For instance, walking and cycling, how do we ensure better possibilities for walking and cycling? What's the public transportation supporting walking, for instance, or sports facilities, greener areas, whatever. So this is a holistic approach, and from the mayor level, from the political decision maker, and from us leaders, we need to be involved and be responsible.
Yeah, and Anne, a minute ago you talked about diabetes and cardiovascular disease, and I'd like to stick with the latter for just a second. You know, data has the potential to revolutionize how cardiovascular disease is managed. Can you share how predictive analytics can now be used to transform early detection? And then I would take it even a step further, and what else is needed to, say, eliminate heart attacks in the next generation?
Yeah, that's our goal. Well, we have examples where we use the predictive analytics now to simulate interventions on the one hand, and that's what is very interesting for health authorities or city authorities, that you can forecast what is going to be the health impact and the cost impact of this interventions versus that intervention. And then you can better plan your roadmap towards population health. So that's one example. Another example is that now it's possible, and we did this with our partners in Singapore, we can predict who will experience an acute event or even who will develop a cardiovascular risk factor without the need for clinical exam or biological sampling, only based on these underlying determinants. So you can start predicting who will develop cardiovascular risk, then you can start acting on it and target your interventions of early detection to those population groups. That is really the goal of using all that data work. And to your last question, this is my dream, that we can eliminate heart attacks for the next generation, truly. If we bring together all the scientific innovations, we have these fabulous advances in how we approach obesity, hypertension, hypercholesterolemia. All of these exist and are available. If we couple that to the technology progress and the technology innovations with these predictive tools, then we can eliminate heart attacks in the next generation. We are going to try that out in a few cities around the world.
We will always have limited resources, and we need these kind of tools to reallocate those limited resources. We need to make choices. We need to make choices based on evidence. In healthcare, we are used to make choices based on evidence, but in everywhere else, we need a better evidence base using AI, using these huge amounts of data we already have.
Thank you. And with that, I'm actually going to ask our other panelists to join us. We have, okay, great, and I'm going to try this in order. Elena Bonfiglioli Microsoft's global business leader for healthcare and pharma life sciences, and a champion of women's health. We have David Napier, professor of medical anthropology, University of College London. Daniella Foster, senior vice president and global head of public affairs, market access, and sustainability for Bayer. And Michelle Williams, professor of epidemiology and population health at Stanford University, and the former dean of faculty at Harvard's Chan School of Public Health. Thank you all for joining us. We have a lot of people and a lot of things to cover in a short amount of time. So I'm going to start and actually ask a question that I would like all of you, we can go this way, we can go this way, it's up to you. But we know by 2050, 70% of the world's population will live in cities, obviously making them pivotal arenas for shaping the future of health. What would be one element that cities should redesign today for a more resilient 2050? Michelle, I'm actually going to start with you.
Happy to start. First of all, thank you. I really enjoyed listening to the fireside chat. And I want to pick up on what Anne and Juha said. Being proactive requires us to have an insight into what we need to act on. And I would love to see every city, including this wonderful city of New York, have a data ecosystem that would allow for readily accessible information to allow decision-making process. And as a global citizen, I'd like to see that in all of the cities across the globe. But I recognize there's a cost to doing this, and it will require governance to protect, secure, and provide the access to the data in a fair and reasonable way to those who can use it. But it will also require entrusting, getting the trust of citizens who will share their data for the kinds of work, prediction, and evaluation that you heard our speakers talk about earlier.
Absolutely. Daniella?
So I think on this, one of the things that's really important is to meet people where they are. And that's the beauty of being in an urban environment in a city. So I envision a world where every touch point that you have throughout the day, whether it's the bus stop or the park bench or et cetera, becomes a place to help improve your health. And why couldn't we design cities so that that's baked in, not just baked into the hospital, but why can't it be baked into the pavement? And there's some great innovation that enables us to do that. So at the end of the day, I think it's about meeting people where they are, where they live, where they work, where they worship, because the reality is that the majority of time you may be spending, on average, the data says, between an hour and a half a year with your doctor. The rest of the time you are living. And in between those times, you need to self-care, ideally science-based self-care, pulling that through. So if you can design the environment to do that, we'll have healthier populations overall.
I love it. Baked into the pavement. I like that. David?
I'd have to say health inclusion. And in particular, given what you just said about the isolation as being a key social driver, non-clinical or non-medical social driver. And I believe that if we understand, as you said, that there are 8,000 some hours in a year and only a few of them are spent actually in a care delivery system, that health is largely, no, it is made outside of the health sector. And therefore, understanding people where they live and how they themselves perceive themselves to be included or excluded is what I think is the tipping point that structures their health agency.
You would guess from Microsoft perspective, I would say data. And I will say data. I will say data. But before that, I would say how fantastic would it be if every city could hold the banner of healthier city, which means a policy for that, an integrated policy for that, an integrated governance, and the understanding that healthier cities, healthier individuals is not about the time, the hour and a half we spend at the doctor, but it is about an holistic view of the data. So combining those data, integrating social determinants of health across the various parts of the cities, across the various silos in the city, because we live in the city as individuals, It's about nutrition, it's about mobility, it's about education, it's about social connections, it's about elderly care, it's about all of those things together. So can we have a view of our score as individuals, but also as a city, and really create a healthy competition to make sure that individuals are. Technology is not a problem per se. We can have an integrated data platform. Is the incentive there? Is the governance there and the political leadership there to make it happen?
Juha?
Excellent points of view. I would like to say from the city perspective that I think we should need realigned like partnerships or collaboration models. Of course, city organizations are important, as I said before, but also private organizations, third sector organizations, of course, citizens and communities themselves. We still have a lot of power there. We could use more and align these better together, and also use the power and the sites that we might have from the citizens or the communities. We have the data, we have the AI, but then we also need to have the vision from the citizens. How do they feel? What is their experience in when we're, for instance, implementing these actions? How do they feel? How do they approach these kind of actions? It's very important.
Can I make a comment?
Of course.
Data is being looked at as a passive thing. It's almost like a silent asset, because it sits in repository, it needs interoperability, you need to do a lot of wrangling, hours and hours and money to activate the data. Let's face it, right? Silent capital. The reality is that data saves lives. You've proven it. You two together have proven it from Finland to New York. We can do that. So the question is, how do we activate those data, and how do we encourage, in technology we say nudge people? Behavioral economics has taught us that. So get the data and reason over the data and nudge people that want to be healthy to do the action to be healthy. So from passive capital to action. And in the era of AI, that's all we can do.
Thank you. All right, Anne?
I think everything is said, but I would say responsibilize the individual and integrate it everywhere in normal life. As Daniella was saying, that's really how cities should think about this. It's not linked to the health system. Your health is linked to your conditions in which you live.
Excellent. All right, Michelle, I'm going to come back down to you. So given your incredible career in public health and epidemiology, and then all the things you heard on stage before you came out, how do you see these advanced data analytics being instrumental to turning the tide? I specifically would like you to talk about in chronic disease.
Yeah. You know, the answer is embedded in all of the responses you heard. If we can get all of our decision makers at city levels, but also in households, to recognize that decisions can be informed with the passive and active data all around them, we could build an environment where people are making wise choices from a policy perspective, to a family resource allocation perspective, to the employers creating an environment where people are being productive, they're being present, and everyone is thriving economically, socially, and of course in their health characteristics. The data can help drive decision-making, but only if we bring it to the level of understandability and actionability. And what I love about the AI for Healthy Cities, despite the very hard work that we've had to do to organize the data, that we're all in these different silos, to bring all of the stakeholders together, public, private, academic partners, philanthropic partners, industry partners, bring them together with the one mission, and that is, how do we aggregate the data, manage it safely, analyze it wisely with enough humility to recognize that real world data are messy. Because the questions that we're asking and answering of the data are not the kinds of questions you would do in a randomized control trial. We want data around how people are spending their time in communities. What are the decision factors that enable or disenable physical activity in a community? These are social variables, they are biological variables. They are some of the variables we don't even yet have real names. So we just have this blanket of real world data. But it's the understanding that real world data, liberating the information in that about individual risk, family risk, community risk, city risks, that will enable the proactive decision making for wise allocation of resources that are always limited, but the allocations can be done smartly to support and enable, for example, reducing the burden of untreated type 2 diabetes in this city, which is a massive problem, but it does not have to be if we can identify the places and the small communities, be very hyper-local and intentional in how do we improve the access to healthy foods as opposed to processed foods in the community that has a high burden of type 2 diabetes that's untreated. How do we mobilize people who are not accessing the pharmacotherapy or the physical activity levels that they can use to bring down their blood sugars and reduce their risk of losing a limb or developing end-stage renal disease? Those are the questions we can and should be asking with the data we have to enable better decision-making, to pinpoint meeting people where they are so that they can achieve a healthier lifespan.
Thank you. And that to me makes a natural segue. Elena, I want to talk to you about Microsoft's AI for Good. And so very broadly, I'm just going to ask, based on what Michelle just said, how do you balance innovation and practicality?
Thank you. And first of all, just a word on the AI for Good mission that can be declined into AI for health, AI for humanitarian, AI for, there's different global challenges that we aim to solve with AI in partnership with others. So AI for health as a subset of that. First of all, we've been very, very fortunate to find the Novartis Foundation as one of our key partners, seriously, because you said, roll up your sleeves and let's go do. So already from that theory, from an unmet need to a solution in the city. So where the strategy meets the practicalities is that the strategy is about identifying a need, unmet need, and then mapping it with, from our perspective, technology capabilities and complementary capabilities of the partners that are part of the solution. And then, in this case, really getting to the data that would inform real solution. I still remember discussing with Han, how do we go from real-world data to real-world data-driven policy? And that arc is what, in the 6 years, all these partners have been bringing together. And really, I applaud the courage also of, Helsinki as the first city that said, yes, we're in. You are amazing in terms of healthcare on the global map, in terms of preventative and so on. But every single city can follow this blueprint. Now the path is chartered. So it's who's next, who's second, who's third. And each of those cities will actually bring next step of innovation from which we all gonna learn. And what they have done, what we have done in cardiovascular, is a blueprint for many other conditions that have comorbidities, where we need to look not at the clinical data sets only, but at much broader data sets to really charter a path for healthier individuals.
Can I just add one little point, because I loved that response, and I love the idea of competition. How can we do better? But what I also love from my experience when working with Juha is in looking at the data you already have, some of those 250 slides. Not only do we see reason to celebrate excellence, but I sat at the table and I saw you and your colleagues say, but we can still do better. And I think that is the power of data.
Yeah. So I want to switch gears just a little here. We're talking about data. But David, I want to come to you. And I want you to talk to us, and if you could give specific examples of how ethnographic research in cities, I know New York, Singapore, and there's others, but are there any cross-cutting insights coming out of qualitative research?
Yes, absolutely. And I think that, first of all, it's important. Qualitative is often a stigmatized word because it's not quantitative.
Yep.
But actually what we're doing is collecting real world evidence and looking at how risk factors compound one another in real time and trying to measure those so that they're scalable to some evidence base. So I'd like to get that part on the table first of all. But I think that they're really, in terms of cross-cutting insights, I think there are three that stand out, and they've come up in this conversation. Clearly, the first is that entry points matter. That is to say, you need to know where to meet people in a place where we're actually going to be able to communicate in a way that allows people to understand that communication improves their health agency. So that would be food security, food support programs that doubles as gateways for care here in New York or in Singapore. It could be, as you were referring to, it could be data-driven online services that, or active aging centers that perform this function for communities. Because these, whether they're virtual or real, they become touch points for that kind of exchange. So I would say, first of all, entry points matter. Second of all, I think it's really important for us to realize that time poverty, which is a word I hope everybody walks out of here remembering, is structural. And which is to say that in all cities we have barriers, and it clearly time poverty is a barrier. To give you a specific example of a single mother living in a food desert with a special needs child, and she's HIV positive, living on a fixed income in a dangerous neighborhood without good transportation. Right. That's how time poverty becomes structural, because that person's life is simply calamity coping. But it's also structural insofar as if you are anybody in this room and you commute long distances to work, as we were just talking about earlier, what's going to happen is that time you spend commuting back and forth is going to impact your hypertension to the point where your rates of diabetes are, we've documented this, are as high for college-educated people who commute as they are for the other person that I just mentioned. So I think we need to realize that these city problems are not just of a particular stereotype group. They're things that we all share at some level. It's just that those of us who are sitting here have health agency, and those who are in a state of calamity coping don't. The third thing, I think, and you brought this up very nicely, is that data sitting passively. I mean, translation is infrastructure, isn't it? And it's a community. It's how we connect, and it is alive. So that in the sense that on the one level, it could be literal translation services required by people who can't communicate. And I would say that in clinical setting, that goes for everybody. I mean, I don't think our clinical engagements are all that communicative if it's a 6-minute engagement every couple of times a year. So I see this as this occurs across the spectrum. It's not something that they need and we don't. Mm-hmm. So I think that's a really important point. And also, this idea that the translation is also a function of community engagement. That is to say, of being proactive in reaching out to people who don't have the health agency, who remain invisible, who cannot present themselves in focus groups, who cannot fill out 14-page forms just to be able to get a social service. So to me, this is also a human engagement issue. And I could say a whole lot more about this, but I think that the question, really, the big challenges here are how we enhance involvement of citizens in population health. And of course, this starts out with trust, which has already been mentioned. And clearly, there are many ways in which trust is created. Where formal services are absent, we have to think about faith-based communities, about housing authorities. We need to think about businesses, the private sector, as we've already said. But I think the key for me in terms of AI for Healthy Cities is, for the very first time, we're actually starting with those complex, heterogeneous risk factors that compound one another in real time, that aren't amenable to randomized controlled trials, or to simple social determinants of health analyses that say, because you were raised this way or you have this family history, this is going to happen. That these compounding things can actually be worked. We can actually scale these definitions, these prototypes of real people that we all know, because I think the people that I mentioned, we all know, at least the commuters, and some of us, if we're frontline health workers, know the other example that I gave. That we can scale that to some evidence base. And what I'd like to do now, before I say any more, well, obviously this is meant to be a conversation, is to run just a really short 1-minute video. These are just snippets. These aren't results. They're just snippets of things that have happened on the street by our field workers here in New York City.
Yes, that's
The last one.
Thank you.
Thank you. You could hear people
Thank you.
gasping during.
Yeah.
Wow. Daniella, I want to jump down to you. With your experience as we're talking and we're watching this video and talking about partnerships, what can private sector strategy or what private sector strategies can be used for public health goals, for impact, to improve health? I mean, all the things that everyone else has been talking about.
And so just those few small things after that wonderful video. So maybe a couple things before I dive into that. I'm curious from the audience, a raise of hands. I can see some of you. How many of you in the audience know your 10-year risk of heart disease? Okay, there's a few of you.
Less than 5%.
Yeah. Wow, amazing. Thanks. So,
Reading the room.
exactly. I mean, a couple of things I want to bring up here. When we're talking specifically about heart health, two of the biggest key areas here that we've identified is one, awareness. Do you know your risk level? Do you know what the symptoms could look like? Have you been checked? And then the second is diagnostics. And you've heard quite a bit on here about social determinants of health, qualitative, quantitative. But within this space of diagnostics and lowering the barrier to entry is absolutely key. And the reason that I bring this up in the context of partnerships is one of the things that we've realized, and I'm a firm believer of, is that we have to transition away from a system that's based on sick care to one that's based on well care. And in order to do that, you have to do that in partnership. It has to be in partnership with communities. It has to be place-based. It has to be in partnerships with government, with the health systems, community health workers, academic institutions, all of that. To fundamentally shift the paradigm in health, you have to do it in partnership. So that is why today, at this moment, I am incredibly excited to announce that Bayer is partnering with Novartis Foundation on the Cardio for Cities initiative. We share the mutual goal to end deaths from heart attacks in a generation. We also have our own goals at Bayer, but these are, I believe, the types of partnerships that need to happen. We're gonna focus right here in New York City, so it's incredibly place-based, building off of the data, the work that's been done in hospitals with community health workers, et cetera, to tackle this at scale. So I'm incredibly excited about that. To the point on some of the things that have worked, I do think partnerships work. That's absolutely the way forward. The second piece, you heard me talking about meeting people where they are. I firmly believe it has to be place-based, which is also why I'm excited about this partnership. And we've seen this work in other places. We've had experiences partnering with the government in Egypt, specifically focusing on underserved hospitals, specifically focusing on screening so people could understand their risk and then move forward to treatment. Also thinking about new tools and diagnostics, we've partnered with tech startups that will help eliminate the barriers to risk. So for all of you who did not raise your hand, there is a tool out there, the Heart Health Risk Calculator. You can take it on your smartphone, has over 90% accuracy, and it will tell you your 10-year risk of developing heart disease. I personally have heart disease. I have taken it. I was really surprised at how accurate it is. So this idea of awareness, diagnostics, and then that translating into place-based solutions and also going into your provider and making those screenings, all of those tools end-to-end coming into a community is essential. So we've seen that work. I'm incredibly excited about this partnership and scaling it up, and we want to take it to more cities, and we need everyone. I think that's an important piece of this. This is not a single individual job. Cardiovascular disease, #1 killer globally, and it presents differently, for example, in women. So going back to these pieces, awareness, diagnostics, thinking about it end to end is essential.
Thank you. And say it one more time, because I saw a bunch of people start writing.
Yeah, it's the Aspirin Heart Health Risk Calculator.
There you go. Okay. And so I want to, well, we're talking about partnerships. After that video, there was something I was thinking about, and I'm going to start and address the question to Michelle, but I'm very curious for all of you to jump in if you want. And that is, as we talk about all the things that are possible, is there a risk that poor cities could fall behind? Is it the opposite? Is there the potential that we leapfrog and we move from a 2 to an 8 as opposed to a 7 to, right? What are the risks?
Yeah, that's such an important question, especially after seeing that film. But listening to Daniella talk about partnerships, I want to start there. I'm an academic. I've been in the knowledge generation and teaching business for 40 years. And one of the true statistics is that innovation only begins to reach populations in impactful ways 17 to 20 years after that innovation. So all of us are at risk if we are not intentional in making sure life-saving innovations get into the hands of the people where they are so that they can understand it and use it. Now, I'm a data geek. I don't think I've hid that from anyone. And I'm extremely excited about where we are today with the power of analytics that we have at our fingertips. And we're just at the beginning, okay? Which means if we do it right, we will be able to learn in real time ways to save lives. But we have to find ways to communicate it effectively. And we have to find ways to make sure that the innovation reaches everyone. Because if we don't, we will be driving the disparities and we will continue to see those heartbreaking stories around inaccess to health, poor communication, lack of time to take care of oneself. All of this will only continue to grow on an exponential level if we're not intentional. What I love about where we are is we can, in real time, identify those populations that are isolated, that are not necessarily visible to us, that we can design and be intentional in designing ways to get to those populations. So I no longer necessarily feel anxious when innovation comes along. I feel empowered because of the partnerships and the intentionality that these partnerships, and some of them you've heard about, are in making sure that we're not leaving the hidden populations behind. David's discussion about the importance of qualitative data is a fundamental pillar for this, that all of the problems that we're facing will not be solved by technology. We still have to embrace the human side of the business that we're in, and that is improving lives and saving lives and increasing the healthy lifespan for everyone everywhere. That's global health, that's public health.
Absolutely. David, would you like to add on to that? I asked if you'd like to add on. I saw you nodding along.
Oh yeah, absolutely. I'm sorry, my head was turned that way. I think that one of the key things, of course, is just determining whether the cup is half empty or half full for those that have less. And there's an argument to be made both ways. And allow me to try to make that briefly. When we do our vulnerability assessments, we not only look at utilization of services, we look at social capital and try to understand what, in the absence of those formal services, who actually steps in. Is it a faith-based organization? Is it a community activist? Is it an NGO? Is it a business? As you were describing, is it an initiative that's incentivized by a business that's helping to keep a community thriving? And we try to understand whether those are actually scalable, because there is some innovation in those activities. So to get to the point of cities having less, I think that if we find a way in which we can transfer that knowledge, it might just be like villages in the global south that went from no telephone lines to cell phones and cryptocurrency. That is to say, there may be forms of innovation there that we've yet to know about that will become much clearer to us if we actually pay attention to people at the community level and identify where they get their social trust and how we can actually nourish that.
Thank you. Speaking of that social trust, I want to come back to how we started this, talking about the relationship, because that was where trust first came up. So Juha and Anne, and honestly, Daniella, all like now these partnerships, as we keep talking about, whether it's announcements or long existing partnerships. We want to see these models grow. We want to replicate them. We want to multiply the impact. As Elena said earlier, are we having fun? And are we having an impact?
That's right.
And can we do both together?
And can we do them at the same time? So, I want to start with you guys, but I want everyone to expand. What is it at the core that you two think makes your partnership so successful?
Well, I can start. Of course, I do have to say that I have very capable people in my organization and in my teams. And yet, we're not the experts in data analytics, in AI, at least at the moment. That's why we need partners. We need the most capable people and teams in the world to have the best possible outcome from the data. AI is not a silver bullet. It's an enabler. We need to validate the data or the results we're getting from the analysis. And of course, we're doing that, but we need all the expertise we get from the other cities, for instance. If we can copy, if we can reflect, if we can benchmark our findings, and of course the actions also, but the findings with other cities. And of course, we do get from the collaboration and with this initiative, we get these fantastic global experts. I wouldn't have these people in this collaboration with me without this kind of partnership with, for instance, Novartis Foundation. So that's the real value, added value for the city.
Anne?
I think the reason for success is that we have from the start the same goal. We set the agenda together, but we have the same goal and we speak the same language. I feel these partnerships with public sectors, but also with private sector players, we leverage so much more when we are together. The sum is much more than 1 + 1. It's multiplying impact very rapidly. And it's because we speak the same language. We want to measure everything. That's a given for private sector players by definitions, but now also for many cities, like you are giving the example, Juha. So it's shared measurement, shared glory when we get there, and that makes it very powerful, because if you're alone, you don't go that far, and you have to go together to go far. And I'm really, really very, very thrilled with this new partnership with Bayer, Consumer Health, and all of the other partners. We have such an honor to work with, and it's a real fun, as you say, Elena. Yes.
And it's about saving lives.
Yes.
Mm-hmm.
I think that's the goal at the end of the day. And it makes you feel good to wake up in the morning.
Exactly.
It's also about leadership, and we see it reflected here. We see leaders who are willing to step outside of their comfort zone, to step outside of their own siloed sectors and do something novel and potentially disruptive. And so I don't think we can underappreciate the importance of the leadership that's reflected here in Anne and Juha, you know, in you, Elena, and Daniella. And we academics, David, we're just here to coach.
We cannot do it without you.
Maybe a reflection on where we are in the journey. Because you said, you know, shared celebration of success, but we went through shared pain of trying, of disbelief, of excitement, of then difficulty, and then you guys really proved that it's possible. And normally that is a very heavy lift. If you think back, it's almost like 6 years of journey.
It's long.
Yeah, it's a long time. And it doesn't have the opportunity here for all of us, for all of you that are here and interested in this, is to say, it doesn't have to take 6 years next time, because the time is shorter, right? It's almost like you are in a room and you have a beautiful toolbox that you have seen it works. So the question is, how do we activate cities that are willing, but probably overwhelmed in this journey? And that's where the recipe of success can be further repeated, and where organizations from the private sector can be an accelerator, an enabler to say, okay, how do we apply it from Helsinki and Singapore and New York to 10 more, to 20 more, to 30 more, as a learning coalition. And I think that is where we should really see diffusion. In technology, we talk a lot about diffusion. You can have the best solution, but if it doesn't reach the capillarity of use and accessibility and affordability and ease of access, you know, entry points, it's not going to be successful. So that's my hope for the next steps, particularly because we have seen that in cardiovascular, in COPD, in diabetes, data can uncover people that are walking around with high risks, not knowing, Daniella, as you were saying, but also high propensity of exacerbation, not knowing. They don't know, health systems don't know, nobody intervenes, but the toolbox now is there.
Your hope gives me hope. And when I hear you say 6 years doesn't have to take that long, my entire public health career, the number that Michelle used is the one I've always heard, right? Which is from inception to public uptake, 17 years.
17 years.
Or more, but 17 has always been that number for decades now. So that gives me a lot of hope. So I have a question for all of you before we end, but David, I want to come to you quickly. And I want you, again, just the powerful video and all these things, I want to come back to risk. And I know we addressed it a little bit earlier, but what are the risks of ignoring community dynamics when implementing interventions?
Yeah, I'd like to, I think depression, no, but I'd like to, I really would like to go back to answer that question through what you've just been talking about in terms of fun and next steps. I can't tell you how much fun it is to carry out a vulnerability assessment with an elderly woman who lives on less than $10,000 a year in New York City, and her response be, can I learn how to do this? That is to say, this means something to me, and I understand what you're trying to understand, and I'd like to help. Now, to me, that's kickstarting community engagement, and that's a win-win for everybody. It's a win for the community engagement people you train to do this kind of work, who are excited about it because they see how it's appreciated and that it produces results. And it's a win for the healthcare system because by doing this, you're trying to get a grip on those people that are costing half our pounds and pennies and dollars, whatever, in the last 6 months of life, either through living longer, less healthily, or because they show up in a state of with multiple comorbidities, where 20% of our healthcare budget is spent on diabetes-related, as we all know, mortality and morbidity. We want to make a dent on that, and that's a win for the other side. That's a win for the policymakers, and you and I have had great conversations about this and about the potential for it. So I know I'm going on here a bit, but yeah, I was sparked by you, but I do think that the risks can be addressed, and the risks are certainly there. We know that the risks are big, and the risks are especially big in resource-depleted areas. So we really have to get at that community level if we're going to be able to make changes with the tools that we have and the opportunities that others don't.
Mm-hmm. Thank you. All right, so one question for all of you. If we were, not if, in 10 years, when we meet back here.
10?
Well, yeah.
Well, we are not
We
so
need a little bit
patient.
of a timeline. I know, but you said 6. We got it. We have to replicate first. So if we were to meet here in 10 years to assess how things have changed in urban environments and to address health issues, what do you hope has fundamentally changed? And then maybe even take a step further, like 2050, like some big goals. But in 10 years from now, what do you hope has fundamentally changed? You can go in any order, or I can point at Michelle again and start at the end. Okay.
I'm going to try 2 things.
Okay.
One, that the disparities that Anne spoke about in life expectancy, that can be as big as 9 to 12 years from one neighborhood right here in the city to another right here in the city, that gap is closing. That's one. The second would be that each citizen of every city in the world walks around with their own health data and the awareness and knowledge of what their governing bodies are responsible for their and their community's public health. Because if that agency and understanding exists at the citizenry, then decisions about who our leaders are, who play a fundamentally important role in our health, will be better decided.
Wow. Good luck, everyone else. Just kidding. Daniella.
Yeah, so I think, reflecting on this, I think we're not just at a turning point, we're at a tipping point. So this transition I talked about from sick care to well care, that's where I would like to see us in 10 years. And I think that takes a few different flavors. So first, I would love to see our partnership save lives. I truly believe it will. And second, I would love to see that individuals become the CEO of their own health, not replacing doctors, not replacing the health system, but again, to that point on science-based self-care and the thing that you're doing the 364 days when you're not in a hospital, that being a core part of how you're keeping yourself healthy, informed by data, being able to leverage the social determinants. So we're helping to equalize some of these disparities and save lives. That's where I would like to see us.
David.
Oh, that's an easy one. I think that I'd like to, Michelle, to see all of your departments of health that you spent your career supporting, that they all have programs where they train community health advocates. That is to say, people who actually know how to do this work, and that we have departments of health that will hire them because they're not only helping people stay healthy or longer, they're also saving the money. Yeah. And if you don't think I'm telling you the truth, just look at the really old studies on clinical time. The most accurate diagnosis is made during the case history. Yeah. 85% of the time, 84% of the time. That's person-to-person engagement. And I do believe that the same holds true here, that we actually, this is a complete win-win situation, and I see absolutely no reason why we're not doing it.
In 10 years, maybe in 5, I would love to be a citizen of a city, any city, any city, that as a declared representative for healthier citizens, a dashboard, a dashboard of which they want to be the leader of that leaderboard. And when they meet with mayors, everywhere else, my score for healthier citizen as top of the leaderboard.
Yeah, they get.
And with that, I think I would love to walk around here in my phone with a healthier citizen agent. We spoke about health agency. But we live in the world where agents, 1.3 billion agents, will enter the workforce. So these are automated things that nudge us and that help us understand the data and so on. I want each citizen to have a few of those to make our life better. And with that, I hope that we will have here the people that have benefited from that, and we will be there uploading that. Thank you.
So, I want to see cities that are healthier, that are smarter, where the healthiest choice is always the easiest one for the citizen. And in that sense, I want to see fewer heart attacks and fewer strokes, as simple as that. Even though cities are growing and aging, fewer heart attacks and fewer strokes.
Yes.
It's as simple as that.
I want all of the above. But it's very simple. I was going to keep it very simple like you, Juha. I want to see cities that finally have all the people who have cardiovascular risk in control, and that they get their own numbers under control so that there's no more heart attacks and strokes. But that's for heart disease only. I want the people in the city to be aware and the owners of their own health and manage their own health. That's going to be the only way forward, I believe.
Well, and with that, we are at the end of our time. And I want to thank all of you, but I really want to give you an opportunity as well, because you're the one who really brought us together. And on behalf of the Novartis Foundation, I'd like you to have the last word.
Oh, thank you, Nicole. Yes, my last word is really a very big thank you for all my colleague panelists here. Daniella, we are thrilled on our new partnerships. I think this deserves a fantastic applause. And thank you so much for all of your attention and support to this ambitious goal of getting to 0 heart attacks, Juha.
Thank you.
Thank you.
Thank you so much.